This is a 38-year-old female with who's been diagnosed with what appears to be a left-sided sigmoid colon carcinoma with multiple bilateral liver metastasis. Her performance status is 0, and she's treatment naive. She appears to have undergone a sigmoid resection, and she's been found to have a RAS mutation, and she's ready to initiate treatment. This young woman, being 38 years old, is a bit atypical for presentation for metastatic colorectal cancer. Unfortunately, this is something we are more commonly seeing nowadays, especially in large referral centers. The average age patient with colorectal carcinoma is in their early 60s, between 60 and 65. And traditionally, the standard of care for screening colonoscopy used to be 50 years old for screening, just because we all know that with time, benign polyps can become cancerous, and that takes 5 to 8 years. More recently, though, there's been alarming incidence of young patients that present with colorectal carcinoma, notably rectal tumors and left-sided tumors. And it is believed in the year 2030 that this incidence will continue to rise dramatically. And as a result of these findings, and honestly, this is something that we've all noticed in our clinics very early on, as a result of these findings, it's now recommended that individuals start screening at the age of 45 instead of 50 years of age. So she is completely an atypical patient, and so we are concerned that potentially could she be associated with an inherited form of colorectal cancer. She does fit some of the typical demographics, being a female and likely having poorly differentiated histology, but she does not have a right-sided tumor, which is more typical for HMPCC or Lynch syndrome. So this patient should definitely be tested for microsatellite instability, but my understanding is that she's was MSI stable. For any patient that presents with metastatic colorectal carcinoma, mutation analysis is needed to be completed immediately as soon as you meet with the patient. And that's really the opportunity to do so. You don't want to wait until the patient has failed frontline therapy before you're trying to test their mutation status. And specifically, as I mentioned earlier, MSI status, whether it be stable or high. Next generation sequencing is an optimal approach for some of our patients, especially if tissue is not readily available. But otherwise, we would test the tumor tissue. But the standard of care for most institutions involves RAS mutation analysis, not only KRAS, which is a more generalized test, but also the other rare RAS mutations such as NRAS and HRAS. This patient should also be tested, as I mentioned earlier, for microsatellite instability. And there's also HER2 new amplification, which is in less than 5% of all patients, but that is very critical to be tested for as well, because that may indicate that the patient would not necessarily benefit from anti-EGFR therapy. In addition, there's also a new fusion protein that the patient should be tested for called NTRK, which is of great interest. That's extremely rare. It's between 1 to 2% of all patients, but there is a drug that is available as well that targets that patient population. We also test for the BRAF mutation. In this case, I wouldn't necessarily order it because we already know that she is RAS mutant, but all patients should be tested for the BRAF mutation as well. That is in less than 10% of all patients, and that's a poor prognostic indicator. Whereas HER2 is not a prognostic indicator, but it may be predictive of benefit of anti-EGFR therapy. BRAF, we now have more focused treatment for those patients. And so we really want to make sure, because of the poor prognosis of those patients, we want to make sure we provide targeted therapy to them whenever possible.